morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audience in different parts of the world. Welcome back to this landmark 250th episode of ACNS webinar today. The speaker for the first session is our honorable guest from Israel, Professor Moni Benifla. Professor Benifla is the head of Pediatric Neurosurgery Department at the Rambam Healthcare Campus, Haifa, Israel, and he was also involved in the establishment of Epilepsy Center there. Professor Benifla performs over 200 pediatric neurosurgery procedures annually, and he teaches functional neuroanatomy and neurosurgery at the Technion Institute of Technology as well as other universities in Israel, and he has received a number of awards for his excellence in teaching. He is a member of several national and international scientific committees and is also involved in the development of neurosurgical robots. He has published over 50 articles in peer-reviewed journals in the field of epilepsy surgery and pediatric neurosurgery. He is also an invited faculty to several conferences around the world. Currently, he serves as the secretary of the Israeli Neurosurgical Society. We are extremely honored to have him today at our webinars, and today we'll be talking about how much to cut, extent of resection in pediatric brain tumors. The speaker for the second session of today is our honored guest from India, Dr. Paritosh Pandey. Dr. Pandey is a consultant at the Department of Neurosurgery, Manipal Hospitals, Bangalore, India. He was previously an additional professor at the NIMHANS, Bangalore. He is an important member of the Neurology Society of India and has held several important positions in the Board of Education of the NSI. He did his cerebrovascular fellowships from Stanford University and endovascular neurosurgery fellowship at the Wayne State University, Detroit. His clinical interests are focused upon cerebrovascular skull-base surgery, infections, and neurotrauma. He has over 100 publications in various peer-reviewed journals and over 200 invited lectures at several conferences. We are extremely honored to have him today at our webinars, and today he'll be talking about surgical and endovascular revascularization. The chair for the first session of today's webinar is an honored guest from India, Professor Suchanda Bhattacharjee. Professor Suchanda is an additional professor at the Nizam's Institute of Medical Sciences, Hyderabad, India. Her clinical interests are focused upon pediatric neurosurgery, and she also heads the epilepsy surgery program at the institute. She has several publications in various peer journals, and she's also an invited faculty to several conferences around the world. We are extremely grateful to her for accepting our invitation to chair the first session of today's webinar. The chair for the second session is our honorable guest from the USA, Professor Sabrish Natarajan. Professor Natarajan originally hails from Madurai, India, and is currently the director of brain tumor, skull base, and cranial neurosurgery, and also the consultant in cerebrovascular and surgical neuro-oncology at the Institute of St. Vincent's Healthcare, Jacksonville, Florida. He is a member of ACNS, CNS, as well as American Society of South Asian Neurosurgeons. He has been rewarded with several awards and honors for his outstanding contribution to neurosurgery. He is a hybrid trained neurosurgeon and specializes in both clipping as well as coiling of aneurysms, and we are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both speakers and chairs to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this on the WeChat channel. Dr. Liubun Seng from Malaysia is my co-host for today. With that introduction, I would like to hand over this online podium to our first chair, Professor Suchanda Bhattacharjee.
Thank you, Dr. Raja, and thank you, ACNS, and my regards to Professor Kato and rest of the members of ACNS. So we have a session today by Dr. Moni Benifla, and I see his interest and my interest seems to be the same. So I have not met him personally, and so we would be very glad to hear from him, because this is an area of pediatric brain tumors which is really confusing as to how much you need to take out. Sometimes we know we always talk about, like, you take out the whole bit of tumor, and radiologically, if you do not get to see them, then there is more than 85% survival these days at 10 years. But then the question is, how much is the complete excision? Still, I don't think so. All of us have that answer as of yet. And with the everyday increase of information on pediatric brain tumors, genetics, epigenetics, transcriptomes, everything. So things are getting more and more difficult for us to know, like the curve is shifting from surgery towards medical management in many of the tumors. And the different tumors are coming up with new classifications, and we really need to know in depth about which to operate, how much to operate, and when to operate, besides the other modes of treatment. So with this little bit of words, we would like, and we are eagerly waiting to hear Dr. Moni Benifla, and let's request him, and I hand over to you, Dr. Moni, for enlightening us with your talk.
Well, thank you so much First of all, what do you mean we don't have answers? We are neurosurgeons. We know everything. You know, we are the smartest guys on earth. So yes, I totally agree. We have no answers. So thank you very much for inviting me to give this lecture. I'm from Rambam Healthcare Hospital in DC. So I'm going to speak about the extent of resection of pediatric brain tumor. As was mentioned before, this is not a clear-cut answer. And I'm coming from Rambam Healthcare Hospital, which is actually almost the only hospital in the world that is relying on near the ocean. And from my room, you cannot see it now, but from my room, you can see clearly the ocean, which is a perfect view. But I was born and raised in Jerusalem. And Jerusalem, for some, will consider it as the holiest city on earth because it's religious it's a saint for the three monotheistic religions, for the Jews, Christians, and Muslims. But as me that I grew in Jerusalem, nothing is saint, nothing is holy. So I always question, and we don't have the answers, especially in medicine, evidence-based medicine. It's not always evidence-based. So the first tumor that I would like to speak about is medulloblastoma. Medulloblastoma, as you probably know, is the most common solid tumor in children. It's coming from the posterior fossa, compressing the brainstem, compressing the fourth ventricle, causing hydrocephalus. It's a WHO4 grade tumor that basically needs to be resected in order to cure the patient. So we see the tumor. Usually the patient arrives with headache, vomiting, ataxia, and then we do the MRI and the CT scan, the MRI, and we see the tumor. And what is the management of medulloblastoma? So the management of medulloblastoma is, first of all, is to perform MRI, total axis MRI, to see that there are no metastases. And if there are no metastases, is to completely resect the tumor, then adjuvant therapy with radiotherapy and chemotherapy. And radiotherapy is a neuroaxis radiotherapy with boost to the tumor bed, which means that the patient received radiation to all the brain and all the neuroaxis. It's important for my next to discuss it further on. So the question is, how much do we need to resect the medulloblastoma? Naturally, we know how much to resect according to two papers that were published, one in 1996 and the other one in 1999 by Wissoff, Albright, and of course Roger Parker, which is a pediatric neuro-oncologist. And in this paper, they prospectively followed children with medulloblastoma. They recruited a patient from 1986 to 1992. And I mentioned that because some of the patients in their paper, in their follow-up, didn't have MRI, they had only CT scan. And they found that the major risk, a major prognostic factor is the extent of resection. And they found that the extent of resection should be up to, most of the tumor should be resected, and the minimal residual should be 1/2 centimeter in area. They found that there is a better prognosis in children older than 3 years of age, and better prognosis in children who have no metastasis, but they found that the children need to be, the extent of resection should be up to 1/2 centimeter area. But how do they define 1/2 centimeter? So it actually was arbitrary. And how you can say that it's 1/2 centimeter in CT scan of 1986, okay? And if you look at their paper, they found that resection of less of 1/2 centimeter improved prognosis in children older than 3 years of age. So it means that under the age of 3, it is not really important to resect that far. The second thing is that it's not so important to resect that much in patients with metastasis. So these two groups of children under the age of 3 and with metastasis, there is no reason to cut for this extent, okay? So this is the first thing with regards to this paper. The other thing that they found that 5 years progression-free survival was 74% plus minus 6% and 56% plus minus 12% with patients with more than 90% resection. So it's actually the same as resecting tumor and to leave less than 1/2 centimeter. So 90% is equivocal like 1.5 centimeter, okay? But they decided to take the 1.5 centimeter in area, not the volume. So from what we see from their papers that were published, the major papers that were published in 1996, 1999, there is no proof that the extent of resection to less than 1/2 centimeter square improve the progression-free for survival in patients with M+, the same as for less than 3 years old. And there is no difference between 90% and 1.5 centimeter. What is the problem with 1.5 centimeter? Okay, and how do we know during surgery if the patient is in M+, because what is the definition of M+, which means that they have metastasis? One, if you see metastasis along the spinal cord. So we do pre-op MRI. Okay, let's say that we didn't see any metastasis, but who says that they don't have malignant cells in the CSF? So how do we know that they don't have malignant cells in the CSF? We know it only ad hoc, so we don't really know it during the surgery. So when we operate these children, we don't know if they are in M0 or in M+, okay? And what about the molecular subgroups that we know that we have now in medulloblastoma? So if we look at these diagrams that were published in Lancet in 2016, we can see that at least for those with subgroup of WNT, okay, there is no difference between gross total resection and near total resection. And what is the definition of gross total resection, near total resection, and subtotal resection? Okay, is there any consensus regarding what is gross total resection, near total resection? So there is no really consensus, but we consider gross total resection, which means that we have no residual, measured residual in post-op imaging studies. Near total resection is actually more than 90%, and subtotal resection is somewhere between 50 to 90%. So we can see that for the WNT group, there is no difference between the gross total and near total resection, okay? And the same as for the other groups, especially for the Sony Hedgehog, as I mentioned, and for the WNT group. For group 3 and group 4, there is a difference between the gross total, significant difference between the gross total and subtotal resection. However, the prognosis is so bad, okay, so it doesn't really matter how much you resect. And if the patient is with WNT, it doesn't matter what we'll do, doesn't matter what will be the treatment. Most of them will survive with good quality of life. So just to show you, okay, it's real dimensions of what is sometimes we see tumors in a size of 6 centimeters, okay? This is 6 centimeters. This is a tennis ball, 4 centimeters. And if we cut 90% of this apple, will reach in volume, will reach this apricot, okay? And actually, this is the area of what we're supposed to leave behind. So you see that when we're going to resect, it's to resect a lot of tumor. So this is on one hand. On the other hand, we always speak about what is maximal safe resection. So maximal safe resection, we have to remember so that once in a while, medulloblastoma, less frequent than epidemoma, that is going to be my next topic in this lecture. Sometimes medulloblastoma invade the brainstem. So invading the brainstem, it can cause facial nerve palsy, sixth nerve palsy, lower cranial nerves, and sometimes they will need track, peg. And if we run after the tumor that is invaded and we want to leave only 1.5 centimeter, we can cause injury to the brainstem. So we can leave the patient with coma, with motor deficits, and there are overlapping blood vessels on the brainstem. So we can cause major infarct or minor infarct, which is sometimes even worse. And not to mention the cranial nerves, that if the medulloblastoma, if the tumor is overlapping the cranial nerves, we may cause injury to the different cranial nerves, the peripheral cranial nerves. More important is the cerebellar mutism. We know that in posterior fossa surgeries, about 25% of the children will suffer from cerebellar mutism. So cerebellar mutism was mentioned in 1917. It was described already by then. In 1949, Brown defined as cerebellar syndrome. In 1975, it was described 2 patients with cerebellar mutism. 1984, Wissoff and Epstein, cerebellar retraction. They said that the pseudopulvar palsy, what they called, caused by cerebellar retraction, Vermian split, and Rickett put the term cerebellar mutism. So what is causing the cerebellar mutism? So people say that injury to the middle cerebellar peduncle, Vermian split, different types of ischemia to different vessels, but we don't know what caused the cerebellar mutism. We know that if the tumor is very big, more than 5 centimeters, there is increased risk for cerebellar mutism. We know that if we split the vermis, there is increased risk, but we don't know who is going to suffer from cerebellar mutism. So this is a paper that tried to look what is causing the cerebellar mutism. And this is a meta-analysis. And when they reviewed all the papers that spoke about cerebellar mutism syndrome, they found that the most important parameters are radical resection and Vermian incision. And since most of our approaches now are telovelar, so we don't cut the vermis, we only retract it upward. So usually we don't do Vermian incision. So the most important thing, the most important risk factor for cerebellar mutism is radical resection. And what the cerebellar mutism does, okay, this patient, they cannot talk. And we know that there is further cognitive deterioration in patients that had a radical resection, cognitive impairment for the long run. And the patient really suffer from the posterior fossa syndrome. On top of that, we have to remember that, as I mentioned before, these patients are going through radiation therapy for the neuroaxis and for the brain. And the paper that also published by Parker that followed these patients for in the long term to look for the quality of life, they found that these patients have very low quality of life. Children with medulloblastoma that were radiated all along the axis, they have cognitive impairments, they have motor impairment, in the paper, no one of them got married. All the patients that they were followed, they don't find work, and they actually social dependent on the society. So there are many side effects to the no-axis radiation. So actually, according to the papers that recommended 1.5 centimeter, so near total resection is as much as effective as GTR. They said it, not me. Radical resection should be considered on individual patient, and sometimes we can consider to leave the tumor, some of the tumor behind, go back to the tumor, and resect it if it's not in a wind subgroup. If there are no metastases, it's okay to go to second look surgery. It also published in few papers that second look surgery has the same efficacy as first surgery. So what about the 1.5 centimeters? It's ancient history. And we also should think what should be the role of neuroaxis radiotherapy according to the long-term cognitive outcome. And to this chapter of my lecture, I should say these papers were published 30 years ago. Okay, we are in a new era, the era of the subgroups. All these recommendations, in my eyes, should be reconsidered. The next tumor that I would like to speak about is epidemoma. Epidemoma, usually we see it in the age of in children below 10, arising from the ependymal cells surrounding the ventricular system. The ependymoma can be supratentorial, infratentorial, or in the spinal cord. And as we can see here in this MRI, we see that usually many times we see the patient arrive with huge tumors. And you can see here the tumor that occupying all the posterior fossa going down to C2. And we see here that the tumor is going to both Luschkas on both sides and overlapping the brainstem. And the management of ependymoma is gross total resection. We have to cut it because some will say that it depends on the surgeon, how much brave the surgeon is, because he has to reach every cell of the ependymoma. But sometimes the ependymoma is invading the brainstem. It also can invade, as you can see here, can invade the lower cranial nerves. You can see that the seventh nerve is involved here, but I can assure you that in this tumor, all the lower cranial nerves were involved. After the resection, the posterior fossa, the patient is going through local radiotherapy. So this is another example. In this example, also this huge ependymoma. The first tumor that I operated during the COVID time, and back then we were much more afraid from the COVID, so I had on my face the N95 mask, and I can assure you that I was suffered from lack of oxygen during the surgery with the N95. But what I want to show you is that the tumor is overlapping the brainstem, reaching the major vessels, reaching the vertebral, and if you can see here that it's reaching the basilar artery, overlapping the lower cranial nerves in both sides. And we know that without total resection, there is no cure for infratentorial ependymoma. So the patient was taken to the OR, and we sometimes in this patient we didn't use, but sometimes we used neuromonitoring. We use the neurophysiology monitoring for the lower cranial nerves and for Bera on both sides. And the problem is that we had to take the tumor out of the cranial nerves. This patient, we didn't get a shunt, although he had hydrocephalus, but he woke up with some lower cranial nerves deficits. He had PEG for a while, but now he can eat, but he still cannot eat very well, and there are some foods that he cannot swallow, but he doesn't have PEG, doesn't have trach, he gained his normal life. But sometimes, some patients, there is injury to the lower cranial nerves, and they have trach, they have PEG, they have some cognitive impairment due to the hydrocephalus and to the treatment that they get. And the question is, do we have to cut everything? This is a supratentorial epidemoma, as you can see, occupying all the right frontal lobe. You cannot see it in this MRI, invading the orbital roof, increased pressure. The tumor was resected completely. The child recovered with no neurological deficit. However, he has intractable epilepsy, and he's on drugs now, and we may operate him for his epilepsy. So what is the prognosis? Or usually, before we speak about the prognosis, how many patients really receive gross total resection, patients with epidemoma? So for the infratentorial tumors, it depends on the location exactly in the fourth ventricle, how much of them are we able to cut. Usually if it's arising from the roof, the fourth ventricle, so there are some papers that say that 100% of the patients had the gross total resection. In the mid-floor, about 86%, and the lateral recess, only 50%. Some reports reported on only 5% of patients that they could totally resect it. In supratentorial, the resection rate of gross total resection is 25 to 93, and spinal cord less than a half. So since we said that patients with infratentorial tumors are going through a radiotherapy, can we give them extra boost if we leave some tumor behind? Can we give them more radiation to the tumor itself, especially in the era of proton beam radiation? We don't have in Israel proton beam radiation, and we send the patient to Europe to have the radiation. But if we send them to Europe, I don't know how much proton beam radiation there is in other countries. But if you're going through proton beam radiation, and if the leakage of the radiation in proton beam is less than the normal radiation, so can we give them boost to the remnant, and then to save them the neurological deficit? I don't know. I don't have the answer. But sometimes if we can see epidemoma invading the brainstem, or invading the lower cranial nerves, maybe there is a role to leave a tumor behind, to do another MRI, to send them to radiation therapy, and maybe afterwards to think about a second look and to resect the remnants. So what is the prognosis? So there are different papers. Some papers speak about the gross total and no near total resection. I remind you, near total resection is 90%, which means if we resect 90% of a tumor in a size of 6 centimeters, so 90% means that we leave at least a volume of 1 to 2 cc's, even more, even 5 to 6 cc's of tumor, which is visible in MRI. So we can measure it in MRI. So the prognosis is 5 years of 5 years survival rates of 50 to 80% versus 30 to 40% in patients who had less than 90% of resection. So shall our target be gross total resection without measured remnant, or shall it be 90% resection? Okay, and we have to remember that patients with histologic factors that we know it now, with lower H3K27, okay, they have very poor prognosis, and the prognosis is not dependent on the extent of resection. The next tumor that I would like to speak about is craniopharyngioma. Craniopharyngioma, which is a benign tumor, histologically is a benign tumor, WHO1. We can see the incidence of craniopharyngioma is 0.5 to 1 per million during childhood, 5 to 10 years of age. Sometimes we can see huge craniopharyngiomas. The patient presented with presenting symptoms are headaches, visual loss, or some visual issues, including visual fields defect by temporal visual field defects, endocrinology, source status of obesity, and so on. In CT, we can see calcification, but the most important exam is, of course, MRI. And we have to remember that the MRI, some of the tumors are composed of solid and cystic component. And many times the cystic component is much larger than the solid component. So if we take if we decrease the cystic component, okay, we decrease the cranial pressure and we decrease the pressure on the organs surrounding the craniopharyngioma. Just to remind you that this is the cellar area, the chiasma, the circle of Willis, the pituitary gland are all around or near the craniopharyngioma. The craniopharyngioma push all these areas in the brain. So the management of craniopharyngioma is surgery to operate. And in the past, the maximal resection or total resection was considered as a key to a cure of these patients. But the problem is with these patients, and we can see just to see, this is the craniopharyngioma, this is the optic nerve and the carotid artery. You see the craniopharyngioma, which is very, very nice. And anyone who operates on craniopharyngioma know that it's very, very nice. This is an epithelial approach, by the way. It's a very, very nice surgery. It's very nice to evacuate the either side, which is gelatinous, or and then you can take the tumor and to rock it a little bit, and you pull it out, and great result. Okay, you can see everything. All the triangles are clear. The problem is that when you take the tumor out, when you rock it and pull it out, you can pull some of the hypothalamic nuclei. So these patients can suffer severe hypothalamic injury. And this is a patient with hypothalamic injury because they lose the ability to feel that they feel hungry all the time, so they eat all the time, and you can see this fat girl, and they cannot control the eager to eat all the time. They eat. They have endocrinology problems, panhypopituitarism. Most of them will need hormonal replacement therapy. And the question is, do we need to resect it all? And this is a slide that I received in courtesy of the Hoffman collection in the Hospital for Sick Children in Toronto from the 70s, when there is continuing controversy between radiotherapy and surgery, okay? And even by now. So what we do now, I can tell you that, and I had few ASCOs in my during my as a pediatric neurosurgeon, in my early times I used to try and resect all of them, but now I know it's for me and for most of my friends, just to take, if there is cystic lesion, to drain the cystic lesion, maybe to leave a Maya inside the cystic lesion, to drain the content of the cystic lesion once in a while, and then if we can, just to resect some of the solid component, not to go after the tumor, and then to send them to radiation therapy. It does the resection. The extent of resection is not influencing the prognosis of this patient. There are some papers that say that there are, but if you look at the literature right now, especially for those big recurrent phorangiomas, those that are going backwards to the hypothalamus, the extent of resection does not influence the prognosis of this patient, and their prognosis depends mainly on their endocrinology problems and on the hypothalamic injuries. So, although I spoke about 3 major tumors in children that I question the need of total resection, I can assure you that for medulloblastoma and for epidemoma, we do our best to cut it all, because I still believe that there is nothing better than total resection with maximal, of course, maximal safe resection. But now, and for coronary pharyngioma, we moved from total resection to partial resection and radiotherapy. But now I want to take you to to epilepsy-related, tumor-related epilepsy in children. Tumor-related epilepsy in children, because for these tumors, I recommend most of the time, of course, to try and take it out, because most of the tumors that are causing epilepsy in children are tumors that are benign tumors. I don't have much time, so I will go quickly after this slides. We have to remember when we speak about tumor-related epilepsy, that the epilepsy is not arising from the tumor itself. The epilepsy is arising from the cortex surrounding the tumor. Okay, so if there is tumor causing injury to the surrounding cortex, okay, so the epilepsy is coming from the cortex, not coming from the tumor, because the tumor itself is inertic, is from an electrical point of view, is not active at all. Anyways, when we speak about epileptogenesis of tumors, it's multifactorial, depends on the location of the tumor. There is difference between tumor that is located adjacent to hippocampus or tumor is located in the posterior fossa, for example. And sometimes we can see dual pathology, that the morphology in the peritumoral tissue can show cortical dysplasia, gliosis, and other things. So sometimes, in about a third of the patients, the epileptogenic zone is not corresponding to tumor location. So you can see tumor in the right temporal area, and the epilepsy is arising from different areas. So we have to clarify, we have to know that the epilepsy is coming from the tumor area and not from other place. As I mentioned, it's multifactorial, which tumor will cause seizures, and as I mentioned before, the tumor themselves are electrically inert, and they don't have, for themselves, are not epileptogenic. So which tumors are causing epilepsy? So mainly the glioneural tumors like DNET, and ganglioglioma, for patients with tuberous sclerosis. These tumors, DNET and ganglioglioma, are actually benign tumors. DNT, especially DNT, we don't follow the DNT if we follow them, or we don't take them to surgery if there is no epilepsy. And of course, it depends which tumor to resect. What is the tumor type, where it's located. If it's located in the eloquent brain area, if it's located on the Broca area or Wernicke area, we won't run after it to resect it. Depends on the neurological deficit. So if it looks like high-grade tumor, if there is a neurological deficit, and if it's located in a non-eloquent brain area, we know that probably we can take it, we should take it, unrelated if the patient has epilepsy or not. We know that children with epilepsy are special because some reorganization of the language cortex, and there are some different language patterns in children with epilepsy. It makes our work a little bit harder because we don't really know where's the language area, and we know that the language is actually a network and not exactly located the place. And then we need to define the resected area. And I will give you very short case illustration. 6-year-old girl that arrived with partial complex epilepsy. You can see here the tumor, the DNT, okay, located in the left hemisphere, left posterior temporal area near the Wernicke area. We took her to the OR, performed ECOG from the cortex itself, and then another ECOG. After the resection of the tumor, we saw that the EEG normalized. There were no epileptiform discharge after the resection, and the girl is perfectly well, no epilepsy. This is her MRI after the surgery. Another case illustration of a patient with intractable epilepsy. And actually, you can see here the tumor that is located in the mesial temporal area on the right side near the hippocampus. And this patient, we had to know if we want to resect the hippocampus. I saw that this lecture is recorded, so I won't show the video because I don't want it to be online. So the patient had video EEG. We saw that her seizures are coming from the area of the tumor. We exposed the hippocampus. We put electrodes on the hippocampus in order to find out if the hippocampus is involved in the epilepsy. We cut the tumor. We redo ECOG from the hippocampus. And we saw the hippocampus is involved, so we had to resect it. So it doesn't really matter the resection of the hippocampus, but believe me, the hippocampus was perfectly. Anyways, we have to know that in children with tumors that are located in temporal lobe, the resection of the mesial structures did not change the seizure outcome. Okay, so we don't have to resect the hippocampus, especially on the left side, on the dominant side. So there are many other tumors in children, third ventricle tumors that are a little bit difficult to resect, but most of them we have to resect them completely. Colloid cyst, which is not really a tumor, but we see it pretty common. Parocytic astrocytoma, I didn't speak about parocytic astrocytoma, both in the posterior fossa or in the supratentorial. We need to resect it, but since it's a benign tumor, even if we leave remnant behind, okay, most of them, it won't grow. There is a dermoid, which is not really a tumor. High-grade and low-grade gliomas, like in adults. Choroid plexus papilloma had to be resected. And optic pathways glioma and DIPG, DIPG, of course, there is no role in resection, only biopsy. And OPG, optic pathways glioma, sometimes we do biopsy, and sometimes we have to resect it because clinical deterioration and not for complete resection. Thank you. Thank you.
Thank you, Dr. Benfila. Yeah, it was an enlightening talk, and I know there are so many tumors that is difficult to cover everything in this particular this one. But what I understand from your talk is that in medulloblastoma for Sonic Hedgehog and WNT, we go for a complete resection, near total, if not gross total. And for group 3 and group 4, even if you do and exert much, is not going to make much of a difference, isn't it?
Yes. But for the winds, it doesn't matter what we'll do with them. Most of them will recover. Most of them will be cured.
Yes.
But well, we didn't. Nobody really investigated it, but it seems that for the wind group, they have even less than cerebellar autism or other neurological deficit post-op.
Yeah. And is there any question? I don't see, except that someone has asked for like, how much do you resect in a brainstem tumor? So that's someone has asked.
Well, it depends what you call a brainstem tumor. If it's exophytic tumor, if there is exophytic, I use the neurophysiology monitoring. I resect the exophytic part, and I try to, go slowly to resect as much as I can. And if there's some disturbance in the neurophysiology monitoring, so I stop. Because usually it's pilocytic astrocytoma, and there is no point to cause any injury to the brainstem. In the IPG, diffuse interstitial, diffuse intrinsic pontine glioma, there is no role for surgery. Only sometimes for research, we do biopsy, but we don't do any surgery on them. They are going right away to radiotherapy.
Yeah. So, do you use regularly DTI in deciding your approach and all for a brainstem or an optic pathway gliomas? Do you use it as a protocol?
Yes, we use it for all our patients that are going to surgery. I can tell you that sometimes it doesn't make a difference, especially for patients with hydrocephalus, when we drain the CSF. Well, it's a different lecture when to drain the CSF. So when everything is shifting. But we do DTI for all our patients to see the visual pathways and the motor pathways, of course.
Then if any of the panelists have any other question, otherwise I have a lot of questions to ask.
Well, I would like to ask one question to Professor Benfila. First of all, let me thank you for giving this wonderful and exciting lecture. We never heard the other side of the story. We have always read what is written in literature and follow the dogma that 1.5 centimeter is the rule for medulloblastomas and all. Coming to medulloblastomas, I would like to ask you, one of the slides you said that what if the patient has a CSF Mets or spinal neuraxis Met. So in your cases of medulloblastoma, do you routinely send CSF for examination of cells, neoplastic cells?
Yes. Well, if the patient has hydrocephalus and I put an EVD or any before I start to resect the tumor, so I send CSF for cytology from the surgery itself. But if I cannot take CSF before the surgery, so about 2 weeks after the surgery, we perform NP and send the cytology.
I would like to ask, how much is the quantity of CSF that you send for cytology? Because this is controversial.
Why do you ask me the difficult question? Can you give me a more easy question? You have to drain as much as you can, okay? Because you don't know how much is circulating. There are some pathologists that say, don't send me less than 20 cc's of CSF. And then some pathologists say, send me 3-4 cc, it's enough for me to know. You can take all the CSF and the next cc will be the one with the tumor. So we send as much as we can.
Okay, thank you very much. Yes, my co-host Libun Singh, any questions from you?
Thanks, Raja. I have two questions, Professor. I understand the extent of resection is very important for malignant brain tumor in terms of to have a longer progression-free survival, which are not so important, in my opinion, for benign tumor. So, do you have the same definition of maximum self-resection for both malignant and benign tumor? My second question, Professor. For malignant tumor, especially those with central necrosis, in terms of volume of tumor, residual volume to associate with a progression, do you calculate the whole tumor volume or only contrast enhanced region to look at the association? Thank you, Professor.
Well, with regards, yes, maximal self-resection for me is the same for malignant and benign tumor. I have to say that for malignant tumor in children, sometimes it's easier to resect, okay, because it's suckable. You put the suction or the CUSA, depends what you use, and it's coming to you. Even medulloblastoma. As soon, so sometimes a malignant tumor is easier to resect, but yes, I use the same definition for, especially for benign tumor. You know, DNET, it's not as important as to resect as medulloblastoma or epidemoma. And with regards to other tumors, well, the enhanced area, well, in paracytic astrocytoma, you resect the cyst only if it has enhancement. But if it doesn't have enhancement, you don't resect it. But for other tumors, it doesn't matter if it's enhancing. As soon as it's enhancing, you have to resect all of it, because you don't know if there are, you know, the necrotic cells in other areas that are not enhanced. So yes, it doesn't really matter for me. To me, to take only the enhanced area would really make a logic.
Thank you, Professor. I think Professor Pendi have a question, Professor.
Yeah, is there a way to predict which type of medulloblastoma it is preoperatively and then decide your surgical strategy, or it would depend more on the anatomical factors? Would you envisage something is coming this way?
Well, it depends mainly on the anatomical appearance. Okay, so you know, I had medulloblastoma that was reaching the tentorial notch, you know, to the pineal region. So I had to go supracerebellar infantentorial, which it is more risky than a telovelar approach. Many anatomical issues where there is no other way to know which one is going to be easier or harder to resect.
Well, thank you. We have Professor Sabrish Natarajan, who also runs the brain tumor program. Professor, any comments from you?
Great talk. What do you think about tumors like subependymoma? You know, sometimes we see patients who have a subependymoma of the fourth ventricle causing obstructive hydrocephalus, and then sometimes we go and resect it. And there is data coming out that there are some non-enhancing tumors which have a genetic profile or markers which could be more malignant. And some of these patients need adjuvant therapy or more complete resection than we thought before. So this whole thing about, you know, imaging and enhancement is slowly going away. It's going more towards molecular markers and genetic profile of these tumors. So maybe there's a role for radiomics and AI-induced, you know, prediction of molecular characteristics and how radiology can correlate with this, rather than just how crude we were in the last decade. And it's going to refine more. What's your thoughts on that?
Subependymoma. Well, subependymoma is less in the posterior fossa is less frequent in children. Okay, but there is no difference for me if it's subependymoma, if it's ependymoma. For the supratentorial subependymoma, which we see in many patients with which see sometimes. So I think if it's causing a neurological deficit and causing intracranial pressure, we have to resect it. Most of the ependymomas in children do not enhance, because there are sometimes areas that get enhancement. I think maybe 25 to 50% may have some areas that enhance, but most of them do not enhance at all. This is why I showed T2 in the infotentorial. In order for you to see the tumor, I put the T2 MRI and no other MRI. I hope that at some point we'll be able to correlate between the imaging studies and the molecular subclassifications of different tumors, and then we'll know which tumor we should take and which tumor we cannot. This is what I'm implying when I spoke about the medulloblastoma subgroups, and to the decision, shall we resect them or not. But now, in 1996, there were no subgroups. For most patients, there were no MRI. We still depend on these papers from the mid-90s.
Thank you very much. I think we can wind up this session and invite Professor Bhattacharjee for her concluding remarks.
I think it was a great talk, and we learned a lot of things from his talk. And I think we'll have another session if you have to cover rest of the pediatric tumors, because more and more of genetics is coming in, and really we did not have a lot of time to talk about the genetic implication and surgical part about that. So I think we need to you might consider a session on that as well. And thank you, Professor Benifla. And and thank you, Raja, and over to you for the next talk by Dr. Paritosh.
Well, thank you very much. I would like to sincerely thank Professor Benifla and Professor Suchanda for the time and support for the ACNS webinars. So I'll hand it over to our Honorable Chair, Professor Sabresh Natarajan, who will say a short introduction, and in turn invite Professor Paritosh Pandey. Professor Natarajan, all yours.
Thank you, Raja and Professor Kato and the ACNS group for inviting me to chair this session. It's a pleasure to introduce my friend, actually, Dr. Pandey, who I've known for more than a decade now. And he is well-established, known hybrid neurosurgeon, as we know, and is one of the first in the Indian subcontinent to train well in microsurgical techniques and endovascular techniques. He has a lineage of coming from AIMS, trained there for undergraduate and residency training. He came here to the US and trained at the Wayne State to do endovascular work. And trained with Dr. Steinberg to learn bypasses and microvascular techniques. I think the last decade has had a big impact on what we call this as a hybrid neurosurgeon. A decade ago or 15 years ago, there were neurointervention radiologists mainly doing endovascular procedures, and big stalwarts in microsurgery doing bypasses and vascular procedures, open vascular procedures. What happened was there's a big bias. We were not doing the right things for the patients some of the times, because when the patient shows up, you did what you could do in your hands, which you thought was best for the patient. But when someone gets equally trained in microsurgery and endovascular, I stress on the word equally, because there are some unequally trained hybrid neurosurgeons, which I'm sure Dr. Pandey has seen. There should be equally trained microsurgeons and endovascular people who can do complex endovascular work and complex open work. And then they put the patient in the center of these treatment decisions. And I think that is really the concept of hybrid neurosurgery, which is putting the patient in the center and not being biased about what you can do with your hands. I'm looking forward to hear what Paritosh's take is on talking about hybrid neurosurgery today. I invite him to take the podium.
Thank you, Sabresh. Thank you, Raja and ACNS. Thank you, Dr. Yoko Kato, for this kind invitation. There are two parts to my talk. The first part is the most important part, but which is simpler. And the second part is the more little dwindling part, which is surgical, which we'll talk about it here. So I come from a city of Bangalore, but I also hail from Varanasi, which If we take Dr. Benifla's origins in Jerusalem, where three major religions are centered, then we complete the complete arc, because the Varanasi is one of the most important cities of the fourth major religion of this country. Anyways, that's just a coincidence. Cerebral revascularization basically means how to restore the flow to the brain, right? So there are two types of ischemia. One is acute ischemia and one is chronic ischemia. Acute ischemia is now completely in hands of endovascular, even though a lot of us did something with surgical methods before this endovascular era came about. And chronic ischemia is in hands of surgical revascularization mostly, though there are some attempts of opening up a carotid artery, even though there is a complete total occlusion, CTOs, but there is this surgical point of view. The big point is that the acute ischemia part has just exploded from a mere few tens of cases a year. Any good institution in the US should be doing more than 300 or 400 acute ischemic strokes per year. And this is only going to go over and over and more. So this, and as we say this, the chronic ischemia disease, the indication of chronic ischemia disease is dwindling by the day. And there are few very, very established conditions which are there, but most of them are rare in non-oriental part of the world. And the surgery for chronic ischemia, which was one of the most important surgeries, most commonly done surgeries in the 70s and 80s, is now is basically a trickle now. So this endovascular part is like booming, and surgical part is dwindling. So as I said, acute ischemic stroke is in the middle of a revolution, and that is why Sabrish's exhortation of more and more neurosurgeons getting trained in this technique is even more important, because if we miss the most important revolution in the treatment of a neurological disease in our lifetime, or in 2 lifetimes actually, then we are not doing service to the patients that we should be doing. And it is one of the most common diseases affecting to the brain, second commonest cause of death, leading cause of disability. We had IV TPA for 3 to 4.5 hours. Most of them did averagely okay, but not very well. Good outcome was seen only in 30% of patients, rest of poor outcome. And there was poor recanalization for large artery occlusion. Even without this, even till 2013, there was no good evidence of treatment for this disease. So there were like 3 papers which came out in 2013, all of them negative, all of them saying that IV TPA is as good as mechanical thrombectomy, which was because of various reasons. We didn't have the good technique, we didn't have the good workflow. Most importantly, we didn't have the good hardware for all these things. And then, of course, 2 years later, 5 randomized controlled trials were published, and they uniformly endorsed better outcome of mechanical revascularization than with IV TPA. So it's very important for everybody to remember that it is not mechanical thrombectomy in a patient who is not improving with IV TPA. These are patients who are mechanical thrombectomy, and if the patient falls in 3 to 4.5 hour window, IVT plus IVTP versus IVTP. And it was such a revolutionary treatment that the number needed to treat was one of the lowest recorded in the neurological history, of course, and much lower than cardiac procedures, much lower than many others, higher only than decompressive craniectomy for malignant stroke and defibrillator treatment. And it had mortality benefits as well. So these were the various trials. You can see the number needed to treat ranging from 4 to 8 in various trials. And this completely changed the environment. And what has changed, we realized that we need to revascularize very fast. We cannot go ahead and spend time in ER. We cannot spend time putting Foley's catheters. We cannot do a very long GA. We cannot do very long imaging. We also had better revascularization. So even though the Mercy and other trials did show that there were 80% revascularization, most of these revascularizations were only TICI 2A or TICI 2A. these revascularizations were very incomplete, and that's why they were not. Now we can routinely get TICI 2B or 3 revascularizations in almost 85 to 90% of the patients. We had good imaging and we had better patient selection as well. So this is one of the standard workflows. Everybody is activated, ER, stroke neurologist, interventionist, whoever it is. And there's rapid imaging. Depending on the institution, we can have CT, CTA or MRI, MRA. Sometimes nowadays in many institutions in the US, they take straight away to cath lab, do a CT scan, rule out a bleed, and then go ahead and do an angiogram to see whether there is a large vessel occlusion. We haven't reached that. Whether we have to reach that or not, that is a point of discussion. And then we have to revascularize with whatever instruments that we had. An important part is that age is not a criteria, even though the trials were held in age more than 18 to 80. But we routinely do these things in octogenarians and nonagenarians as well. More the NIH, more the benefit is. The time to recanalization has to be minimum. Now, there is something called as DAWN trial and Diffuse 2 as well, which shows that in select patients where there is not a big stroke and there is a large vessel occlusion as well, there is a benefit of these things to go to 24 hours. Now, many people have misunderstood this to say that it doesn't matter, we can just wait for 30 more minutes, it doesn't matter, time window is 24 hours. But that's not true. Each minute of revascularization, delay of revascularization severely reduces the chances of good outcome as well. And then we have various controversies regarding GA and LA. Initially, there was evidence that LA is better. Now there are evidences that if we don't, GA is good as well. So if you have a dedicated neuroanesthetist in town. So these are the various patients. He had a stroke at 10:30, hospital at 11:15. And it's very important for me to say one more thing, is that many times we blame the patient for not coming in time. And in my limited experience, it is a lie. Because once the patient has a symptom, as severe as hemiplegia or aphasia or whatever, the patient will reach to the nearest hospital in the next half an hour to 1 hour. So he has reached a primary physician of contact. Now, from there, it is the responsibility of the healthcare system to provide the correct treatment to him. It's not patient's fault that he has not reached a stroke care center or somewhere around that. It is the healthcare system's responsibility to direct him or there. In any case, that's okay. Patient had a RICE occlusion and IVTP was started. These are very, very routine cases in this thing. And groin to revascularization time was 14 minutes, complete revascularization. We can do this by many, many methods, and we can have very pretty pictures like this. How do we do this? So we do this by 2 methods or a combination of these 2 methods. So there is one method called stent reverse, which are basically deployment of temporary stents at the site of occlusion. So what it does is it enmeshes the clot in its strands, and we keep it for 2 to 3 minutes to completely enmesh it. And then while sucking, we take out the clot itself. So these were the ones which were used in the various trials, and most of the time the solitaire was used, but now there are a lot of them which are coming to the market. The other thing which has now come into market are very large bore catheters. So initially we had smaller penumbras. Now we have 068, 071 catheters which can go right up to the ICA, middle cerebral artery. These are very, very well navigable catheters which can easily go to the middle cerebral artery and suck out the clot. So various operators have various preferences. We tend to start with aspiration catheters, aspiration, because it is easier. It is also cheaper. And if it works, then it works. So basically, it works in almost 60 to 70% of the cases by itself. If there is a hard clot, then we use, along with it, we use the stent reverse. So there are various acronyms that you will hear, that Solumbra and this Umbra and that Umbra and whatever. But basically, it's a judicious use of either of the 2 catheters or a combination of these two catheters. The goal remaining a complete revascularization, which is basically TICI 2B or 3A. These are various classification of the revascularization based on the TIMI classification methods, which is for the myocardial infarction. And basically, it means that the entire middle cerebral artery or whatever territory you are trying to revascularize is revascularized till the end. So that is what is there. So I will stop this endovascular thing right now before saying that mechanical revascularization is standard of care for acute stroke with large vessel occlusion. And if we do judicious imaging, if we have our workflow right, if we have all these things there, then we can really change the outcome of the patient very dramatically. And this is one of the, even though it is simple, it is one of the most wonderful procedures currently present in the neurosurgical armamentarium. And yeah, now we'll come to chronic ischemia. So there are cerebral revascularization with surgery can be divided in two parts, which is flow augmentation, which usually means low flow bypass of STMC bypass or something, and then flow augmentation with various kinds of bypass, and I'll come to all these things. So what is the role of revascularization? Basically, it depends on who you ask. If you ask a room full of interventionalists, the answer will probably be no. Most of the neurosurgeons as well would really not do too many revascularization surgeries in the present times because the indications are so few and everyone tends to gravitate into a particular point of time, particular institution or something like that. So there is, as I alluded to initially, there is decreasing role of surgical revascularization. So the augmentation was hampered by various studies like ECIC bypass studies, COS study, and with stenting of ICADs, which really has, which is still undergoing various trials. And then, of course, the flow replacement thing has been replaced by stent-assisted coiling and now flow diversion. So initially, the standard, the biggest indication of a high flow bypass used to be a large or giant cavernous or paraclinoid aneurysm, which had limited collaterals, which was unclippable. So we used to do occlusion of the carotid artery with high flow bypasses. All of them will be thrown out into the dustbins of neurosurgical history. Is already there, but it will be thrown out in a very, very few years. And even very, very busy intervention surgeons who had large experience of bypasses have their numbers come down very, very drastically because it is very, very difficult to fight technology. In any case, so the techniques are end-to-side anastomosis, end-to-end and side-to-side anastomosis, and we will go through all of them. So for flow augmentation disease, currently the most important indication is moya disease. So it happens, of course, more in the Oriental population. We see a bunch of them in our country as well, whether I see a lot of them, mostly because of the referral bias here. But it is not as uncommon in the other parts of the world as it was initially thought to be. So there are a bunch of papers from US as well, bunch of papers from Europe, other parts of the country, but of course, no one can match the China, Japan, Korea. Then there is carotid M1 occlusion, and then there are other indications as well, and we will go through that. So we know everything about moya disease. It is a chronic cerebrovascular disease characterized by stenosis or occlusion of bilateral terminal ICA with collaterals at the base of the brain. But a fifth or a fourth tend to start with unilateral, and we see a bunch of unilateral symptoms as well. This is bimodal presentation. It is responsible for 6% of childhood strokes and more in females. And presentation is ischemia. Most of the children will present with ischemia. Most of the adults will also present with ischemia, but the number of percentage of people the adults who present with hemorrhage is much higher. And then, of course, seizures and headaches and other things. Our preference is a combined revascularization. In children, a lot of things work. The EDAMS works, multiple burrholes work, all of them. But there is some evidence that the combined revascularization has a better revascularization in the children as well, and definitely in the adults. And so what we do is we do an STMCA bypass in almost all the patients. We attempt at least to in almost all of the patients, and we manage to do it in over 90% of people. And it is then combined with indirect methods like dural inversion and muscle placement. It gives benefit of both methods, immediate reduction of ischemic risk, and then gradual development of collateral. So in our experience, broadly speaking, and I'm talking about children here, is that in half, when we see the post-operative angiograms, half of the revascularization is done by the direct method, and half of them are from the indirect methods with middle meningeal artery, deep temporal artery, and other collaterals which develop over some times. So it is very important to do indirect revascularization at the end of the procedure as well, and not just STMCA bypass. So direct anastomosis is by Tenno interrupted sutures, and we'll see a bunch of videos for that. And then EDAMs for using temporalis muscle deep temporal artery, STA, and middle meningeal artery as adjuncts. So in adults, what we do is that we split the muscle of temporalis muscle, and the inner part of the muscle is placed on the brain, and then the outer part is placed over the bone. So this is a typical patient. He had a bleed here, 23-year-old male. He had a typical Moyamoya disease here. There was no aneurysm found. Sometimes we can find aneurysms in these patients, which can be either clipped or coiled. We have done a few of them. And then this is how we do this. So we harvest the STA from proximal to distal, and then free the STA here. So this is 6 to 7 centimeter incision. Then we prepare the distal end of the STA by completely endothelializing it. We find a good M4 or M3 vessel, which has very little branches. We cut the distal end with fish mouthing, and then we go ahead and clamp the M4, do a good arteriotomy, put a heel and toe stitches, and then go ahead and suture the back end and the front end. So this is not a difficult surgery. You just need some patience and very, very high magnification and some training in microvascular methods. It is very important to be very patient and try not to take the back wall while suturing the front wall. That is the most important thing. And rather than more than doing this, it also improves your microsurgical techniques. So we go ahead and do this, release the STA clamp, and then this is the anastomosis at the end of the procedure. So we can do this. We can do this in children as well. This is a 3-year-old boy, and these are very magnified images, and the technique remains the same. Many times we are unable to find a very good recipient vessel. Donor is almost never a problem, but sometimes it is very difficult to get a nice recipient vessel in MCA, not in terms of the size, but they're very, very fragile. And that is when we don't do direct revascularization and go ahead with indirect revascularization as well. So this is a standard surgery. We'll go ahead and take this off. So you can see that these are various post-operative scans. You can sometimes STA goes and hypertrophies very, very highly. It depends mostly on on the technique, of course, and then also how much the brain demands this revascularization. So sometimes there are very, very good collaterals from the posterior circulation. In those cases, the revascularization will not be that robust as in this case. But of course, these are other images here. So most of the times we tend to find. One more important thing is that Moyamoya vessels, which are here, you can see these Moyamoya vessels here, pre-op. And then when we do very good revascularization here, these go away. And this is important because especially in patients who have a hemorrhagic form of Moyamoya, which are from these vessels, and a good revascularization can have reduction of these Moyamoya, leading to reduction in the bleed things. So these are various things you can see here. So this is about moema. We've done a bunch of them. We are analyzing it, but generally the morbidity and mortality is less than 2 to 3% in these patients, and long term, almost 90% of the patients are free from either stroke or carotid occlusion or TIAs. Coming to carotid occlusions, in the 1970s and 80s, the only good indication for surgery was a carotid occlusion and a good STA, which led to a very large number of indiscriminate STMCA bypasses. Many trials were done in 1985, which showed no benefit of surgery over medical management. Then we went ahead and did the carotid occlusion studies in these patients who have misery perfusion, type 2 misery perfusion. And again, we saw that there is really no benefit. It is not that they did not have benefits, but the 30-day ipsilateral stroke death rate was 14.4%. And basically, this led to an immediate reduction in the STMCA bypasses for these patients. Now, some people have shown that the patients who did not have a stroke had a better outcome stroke-wise than patient who in the medical group, and which can be seen in this thing. So initially, you have a bump of these strokes here, which is basically post-operative, and then you had better. All these patients were protected of stroke, rather than medical treatment, which keep accruing strokes, and probably at 5 years, it would the benefit would be established of surgery. But in general, the evidence is not collected like that, and at 2 years, we had no good reduction in stroke rate. So, and the fact that these patients are sometimes hemodynamically very, very unstable, and even though the surgery is done. Surgery is not a very difficult surgery or whatever, but because of anesthesia, because of flow permutation and combination, because of hypercarbia, all these things, patient will wake up with stroke or will have a stroke in the post-operative period. So these are very unpredictable patients, and that is why we choose them with very, very great diligence. So in most situations, present evidence does not show any benefit of surgery or medical treatment. However, there are some patients who you have to operate multiple symptomatic TIAs in patients with best medical management. And this is one of these patients who had sudden onset irrelevant talk and reduced responsiveness. She had some stroke, carotid occlusion. We put her on best medical management. Again, she had a stroke, global aphasia. Again, there are some more strokes here. There's fairly good cross flow here, but she kept having TIAs here. That's okay. We did a spec which showed hypoperfusion with and without adenosine, and she forced our hand. She underwent STMCA bypasses. She made good recovery, but these patients have more complication rates than patients who have moya disease. So these patients are not the best ones for these STMs. If there is a chronic ischemia, and if there is chronic carotid occlusion with very little symptoms, then they're very, very good indications for surgery. They have low complication rate, but you could argue that they are as good a candidate for best medical management as well. So the patients you have to operate are the worst surgical indication patients as well. There are some other types of patients who have idiopathic ICM1 stenosis here. There are focal cerebral arteriopathy in young, which most of the times resolves with medical treatment as well. Sometimes you have to do a bypass or a stenting. So this is a 32-year-old male who had one episode of stroke, multiple episodes of left side numbness. They tried stenting in another place, which was not possible. The wire did not go through here. So he came to us. We went ahead and did a bypass here. We established hypoperfusion in SPECT, and then we did a bypass, which was a standard bypass, and there is no. So he had a hypoperfusion, which is another complication of these surgeries. So mostly on the left side, so there is a flooding effect of your bypass on the brain. But most of the times, almost 99% of patients, it becomes okay after a week or 2 weeks time. So I really don't consider this as a complication. It is just a thing that happens, and it does not leave the patient with any long-standing issue. How about flow replacement? There were giant aneurysms and patient failing VTO. As I said, most of these patients will be now treated with flow diverters, especially the patients who have cavernous or paraclinoid aneurysms. But there are some patients who have branch arising from the dome of the aneurysm, serpentine aneurysms, fusiform aneurysms, where you have to go ahead and do that. So this is a high flow bypass patient, 15-year-old female, giant ICA cavernous aneurysm. Flow diverter was tried, but somehow the wire kept rolling around in the cavernous carotid aneurysm, and this happens sometimes. We had to fail. Then we went and did a saphenous vein graft here. This is a more difficult surgery than ST-MCA bypass. We take one MCA. We take the saphenous vein here. We can take a radial artery here also, but the size was a problem in that child. Then in the standard technique, we go ahead and do this, but it is more difficult because it is at the depth. Anything which is at a little more depth becomes a major problem here. So that is why these surgeries are used to be done at very, very specialized centers initially. And now even those specialized centers are not doing as much because of various reasons that we said. So I'll just forward this video here. So this is now we're going ahead and doing this in the carotid. You can do it on the external carotid artery. You can do it in common carotid artery. Either of them are fine. And this is the finished bypass here, and this is the filling bypass. So this is the bypass which is filling the MCA territory here. This is another MCA fusiform aneurysm that we did. You can see that one branch is coming out of the aneurysm, and there is very little that we can do here in terms of endovascular methods in these patients. So what we did was we went ahead and put a ST-MCA bypass in this branch, and then we clipped that aneurysm, sparing this vessel. So we'll skip this video here. Side-to-side bypass is one of the more rare bypasses used. It is used in PICA and ICA, ACA, sorry. And sometimes it is also used in middle cerebral artery aneurysms when you have a very, very complicated aneurysm here. I have not done one there. This is a PICA aneurysm where the PICA is going ahead. Nowadays, this is in pre-flow diverter era. Nowadays, it will be treated with flow diverters here. But we did a PICA bypass, side-to-side bypass. And this is more difficult surgery than the usual bypasses here because both of them are at risk. Both PICA territories are at risk, and you have to be very patient to see to get the knot, to not get the knot inside the lumen here. So initially, you go ahead and anastomose the lower end, and then come up and anastomose the upper part. And this is. And at the end, there will be an H, which will be there, which suggests the complete bypass. So this is, we'll just go ahead a little bit here. We take ahead. So this is the H here, or X, whatever you say, and this is the completed bypass. And then you can close the vertebral artery at the time where the aneurysm is. This is another complex DACA aneurysm. I'm just showing it because this can be one of the indications. So you can see that there is a stenosis here. You have a distal one. We went ahead and put a braided stent here, a Leo stent. We have not done a ACA bypass here. What happened was gradually the braided stent occluded, and there was good flow from the other side. But this is one of the patients who could have been treated with a ACA bypass and occlusion of this artery aneurysm. ICIC bypass is popular because there is no need for a graft. This most most used for a complicated MC aneurysm, where one branch of the MC arising from the aneurysm is transposed into the other branch, thus making an unclippable aneurysm clippable. This is the only one of the patients that we have done. I don't have the video, I'm sorry, but this is the ACA. So what we did was we went ahead and cut this branch here and transposed it here, and then this became a clippable aneurysm after that, and we went ahead and clipped it. But these indications are very, very few nowadays. Another thing is blood blister aneurysm. Blood blister aneurysm is mostly now treated with flow diverters, even though there are times when we have treated with these things with high flow bypass and occlusion of the artery. If you see the Japanese literature, the best results actually are in high flow bypass and occlusion of the artery, and the second best results are in patients who have undergone flow diverter treatment. So this is what we have done. Dissecting aneurysms can be done. Many of them are again treated with either parent vessel occlusion or flow diverters here, but sometimes they can be treated with forms of with flow diverter as well. Sometimes it can be treated with deliberate occlusion of branch vessel, especially if you are occluding a proximal branch vessel. It is a good idea to do a bypass here, which is occipital pica, or SCA branch. So this is a pica dissecting aneurysm here. He was recovering from his illness, dengue, and then there was a pica dissecting aneurysm here. You can see this pica dissecting aneurysm. I find many of my endovascular colleagues being very blasé about occluding these kind of picas, which is not a good idea in my view. So we went ahead and did a occipital pica bypass, and then we went ahead and occluded these aneurysms. So this is a standard technique again. Harvesting a occipital artery is much more difficult than harvesting a STA, and that is the major problem of the surgery. And then, of course, the occipital artery is anastomosed to the pica with standard techniques. So this is the completed occipital pica bypass here, and then we go ahead and occlude that artery, proximal pica. SCA dissections, we have done a couple of them. Distal SCA dissections are sometimes well tolerated, but sometimes if you occlude this kind of an SCA, you will have a fairly big stroke, which can be very debilitating. So we went ahead and did a SCA STA bypass, and then went ahead and occluded that SC. Finally, there will be a role for bypass in modern cerebrovascular surgery, but that role will keep dwindling. But that is not a cause for concern, because even if you do a few of them, you will tend to improve your microsurgical skills, and this is an essential part of learning for all the surgeons who are interested in cerebrovascular surgery. So with this, I thank you very much for your kind attention.
Well, wonderful talk, Dr. Pandey. Clear demonstration of your expertise in endovascular and all different varieties of bypasses and clip reconstructions. That's what really, symbolizes the hybrid expertise, right? You should be able to do everything in endovascular and everything in open. A couple of questions for you and thoughts. First is, I really like the way you presented that, this is pre-endovascular era. I did this. I don't do this anymore. I think adaptability of a hybrid neurosurgeon is a very important thing, because technology is going to change every day. And, you have to change your thought process and decision-making and what you do for a patient, depending on the technology and how the field evolves. And you need to have an open mind to do that. And that is a very important part of being a hybrid neurosurgeon. When compared to people who say, this is how I've done it for the last 20 years, I'm going to do the same thing today on this patient. So your thoughts on that. The second thing I think you emphasized is the acute stroke revascularization. I think that is going to be the biggest component of vascular neurosurgery in the future, just because of the disease burden and what it means. And that actually opens a bigger field of being a hybrid neurosurgeon, which means that you are becoming a stroke neurosurgeon, in terms of being a leader in neurocritical care, stroke system development, EMS triage, how these patients show up in a community to hospital systems and how it's taken care of. And I agree with you that the burden of that lies in the health system and not on the patient. Because when the patient is having an NIH scale 10 or 12 stroke, it's not his responsibility to say, hey, he need to go here to have this procedure done. So that's the second thing. The third thing is microsurgical expertise. I think it is dwindling, as you said. Every day, the number of bypasses we do, the necessity to do vascular procedures is decreasing. And it's important for us as hybrid neurosurgeons to keep up our microsurgery. And I think there are two ways to do that. One is, labs, skill set development in animal models, in even, we have Upsurge now, which you can practice anastomosis and do other kinds of microsurgery. Don't cone yourself to doing just vascular surgery, do tumor surgery, which is good microsurgery, and keep having your microsurgical expertise open and developed. Right. So those are my comments. I congratulate you for an excellent talk. And I would like to hear your thoughts on these.
Yeah. So for the first part, one of the major problems that the neurosurgeons had in the initial ISAT era is that they did not adapt to the techniques. They thought that this is not surgery. The endovascular methods of treatment is not surgery. So even now you will go to the conferences where everybody will talk about surgery and coiling. What we have to understand that these are all techniques of dealing with a disease. So this is another form of surgery. If you had that mindset where you thought that this is one way of doing this is another way of doing this is the third way of doing it. So there is a big buffet of techniques that you could do. And if you're well versed in various types of techniques, fairly well versed, everybody cannot be completely well versed with and excellent in all these, but fairly well versed in many of these techniques, you will be able to pick up what works best in your hand for one different patient. I see this in both surgeons and the interventionists who are not doing surgery. Especially in the interventionists who are not doing surgery, their holy grail is how to treat this without opening the head. That becomes the holy grail. And that is also an unhealthy development, because a patient who can be treated very simply by microsurgical techniques is now walking around with various devices there. So it is a judgment call. And I think we are very, very fortunate in this thing that we have a buffet of techniques available to us, and we and the patients, of course, can choose what they want. And it is not us imposing the decision on the other ones. So that is very important. And I'm very glad that more and more neurosurgeons want to take up this field of vascular surgery, which by vascular surgery, I do mean vascular surgery by all methods and not just by opening skull and clipping aneurysms and stuff. Because when I was training, vascular surgery basically meant aneurysm. There is nothing else was there. Some AVMs here and there, but vascular surgery. Now, as you say that there is an acute stroke which is exploded, I mean, there is no way any physician, neurophysician, neurosurgeon will be able to ignore this exploded field of this thing. And if we don't take it up, there are other players in town who are very, very ready to catch the ball. And then we will just be able to there is a song in Hindi which is called Karma Guzar Gaya Gubar Dekhte Rahe, So you will be seeing the dust bowls of the whole technique.
I think it happened in the cardiac surgery field, and we have to look at that. It took 10, 15 years ago when coronary revascularizations, endovascular came through, the cardiac surgeons did not take it up.
Yep.
And what happened was, they lost all their business. it's important to be attached to the pathology and not the technique, as you mentioned.
Yeah. People become slaves to their technology. I mean, if you see even the tumors, people who start doing radiosurgery will do radiosurgery for everything. I mean, you will be amazed to see, and they will, of course, see. I always say that data is like a cricket ball. If you give it to Muralidharan, he will do off spin. If you give it to Shane Warne, he will do leg spin. So you can spin your data in any way possible. We've seen all these things. A good judgment will always involve the experience of the operator as well as the choice of the patient. And once we start thinking in those realms, then we will understand that technique is not the holy grail. The treatment of the disease is the holy grail.
Well, thank you very much. We had very interesting session, and Professor Dr. Parithos showed us how hybrid is the way. As he said, there can be like spin, off spin. We can all become hybrid and players for both. Thank you very much. Any questions for my co-host, Dr. Libun Singh?
Thanks, Raja. Thanks, Professor, for a nice presentation, Professor. I want to find out from you the role or the necessity to have a barbiturate-induced coma while waiting for definitive treatment plan, especially in a major or large vessel occlusion, as if we are putting a prolonged temporary clip, whether that would benefit in terms of outcome of the patient post-intervention endovascular procedure. Or we should, because you mentioned that LL is better than GA, whether that have any influence on the waiting period, what should we do to those patients? My second question, Professor, you mentioned that the acute ischemia is always endovascular. And when do surgery are needed? Do they always play a secondary role to endovascular procedure? And in what option they become a priority in acute ischemia beside decompressive craniotomy? Thank you, Professor.
Yeah. So to answer the first question, barbiturate coma, I mean, these days the revascularization time is so little that it is very, very, you almost never go ahead and do these kind of complicated techniques. Maximum you will do is put a laryngeal mask airway, very, very short procedure, and then go ahead and do these things. So because most of the times we are able to revascularize in the first 30 minutes, if there is, the standard is 90 minutes, of course, from the door, but in 30 minutes we are able to revascularization. So we don't really put this. It is very important to avoid hypotension even if you're giving GA. So that's very important to tell the anesthetist here. And then, these things are there. Regarding surgery for acute stroke, very, very little. I mean, if you see that you have failed revascularization, you have very good collaterals, then go ahead and do these STMC bypass or something. But I haven't done it for many, many years now. There are papers which are there, but I haven't done it. The technology is very good for endovascular, and it will keep improving. And revascularization is not the problem in endovascular treatment for acute ischemic stroke. The problem is correct identification of patient, timing, triage, time for the patient to come to the hospital. Those logistical issues are more of the issues. The issue is not once you puncture the groin. In 30 minutes, most of the subrich will do it much faster, but most of us will be able to do it in the first 30 minutes.
Well, thank you very much. I think it's time, and we can hear the concluding remarks from Dr. Sabrish.
Excellent presentation again, Paritosh. I think stroke system of care is developed and should be a leader in vascular world should look at that as his responsibility. I think that's what, especially in countries like India, where it's still not developed, people like you should take those on to figure out how, to develop population level, stroke services, how people can get to thrombectomy, triage, EMS, hospital systems, ED, and even hospital workflow. I think that is very, very important. The time to recanalization has significantly increased. I was looking at my numbers. Currently my average revascularization time on the table is less than 10 minutes, puncture to recanalization. And our patients commonly are revascularized within less than 60 minutes after they hit the door. So that is not the point. That is not the limiting factor. The limiting factor is getting to the hospital and then triaging through the hospital to your table. That is the limiting factor. I think as leaders in the vascular field, it's not just about the technique. It's about taking care of people with vascular pathology. And the onus, I think, lies in all of us to help the community, the hospital systems, the country to figure this out, how to get these patients to the right place in the right time. Thank you, everyone. I think that was a wonderful session.
Well, thank you very much. That was very well explained, that bringing the patient to the hospital is more important than the door to needle or needle to recanalization time. And I must thank Professor Paritosh and Professor Sabarish Natarajan for making this session very interesting. So I will close this officially now on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Professor Moni Benifullah and Paritosh Pandey, as well as the chairs, Professor Suchanda Bhattacharjee and Professor Sabarish Natarajan, for the time and support for the ACNS webinars. I would like to sincerely thank Dr. Shubin for broadcasting this webinar on the WeChat channel, and we are yet to get an update. And also special thanks to my co-host Liu Boon Seng for joining me today. So until we meet online on 3rd of December, it is bye-bye from all of us. Thank you very much for joining.